All right. Well, again, welcome everyone to the August Behavioral Health Advisory Group meeting. Thank you so much for joining us today. We are excited to reconvene everyone. And if folks would like to go ahead and start introducing themselves in the chat, and we have a prompt here that we'll get to in 1 minute to get everyone reacquainted and introduce some new faces. So for those who are new joining us today, if you wouldn't mind introducing yourself with your name, your organization, and every meeting we like to have a mindful minute. And as I mentioned, we have been on a summer break. So I'm just curious, welcoming everyone back. And if there is a summer activity that has re-energized you to get through these remaining months, I cannot believe here we are almost ending August and getting us through the end of 2024. So if there was a specific activity that you did over the summer with your friends or your family that re-energized you to get back to work. And I can get us started. For those who I've not met yet, my name is Taylor Palmer, and I'm a health policy analyst in the Office of Assessment and Planning with the Prince George's County Health Department. And I I serve with the Prince George's County Healthcare Action Coalition, and I facilitate this group and some of our other work groups. So glad to see everyone today.
And I'll go next, Taylor. My name is Margaret Fowler, and I'm one of the co-chairs of the BHAG meeting. And I work for Totally Linking Care in Maryland. And my mindful minute is my oldest son just turned 25 and had a wonderful trip with him. And he's so excited about his job. And we talked work, I know it sounds crazy, but it just invigorated me that of all the work we're doing and things like that. So it was fun meeting with him and talking about work.
Is there anyone else who would like to introduce themselves?
Can you all hear me?
Yes, we
You all
can.
hear me? Okay. Hi, I am Dr. Gregory Bairstop, and I'm with the uh, Prince George's County Department of Corrections. I'm the Chief of Inmate Service Division, and it's good to see some of the people I know. It's good to see everybody. And I guess my mindful minute this summer, maybe, sometimes they say the little things are bigger than we give them credit for. But I just had a nice moment in New Orleans with a friend at a coffee shop sitting outside. We spent 6 hours outside. I didn't even realize it was that long, but we had a wonderful conversation. And what is there not to enjoy about New Orleans? That's for me.
Thank you for that. I'm also looking at your background, also imagining that we are enjoying the scenery and we have a nice view for today's meeting. Anyone else?
I will introduce myself. My name is Julia Tyndall, and I'm with Inner Dynamics. I'm sorry, I have a very noisy background right now. um, my mindful moment would be my mom's 83rd birthday that's coming up. I'm sorry about the dogs in advance. They're activated by the gardener. So it's nice to meet everyone.
Wonderful. Thank you for joining us.
I'm also going to say hi. This is Nina Ward. I am co-chair of BHAG with Margaret Fowler. I'm sorry I'm off camera. My mindful minute is that I'm on vacation right now to join the group for this call.
Wonderful. Thank you, Nina. Well, and Winnie, I see another hand.
Oh, I just figured I'd raise my hand to to say my name. But I can wait if someone else was talking.
You can go ahead.
Okay. Winnie Moore, I'm with the iMind Behavioral Health. I'm their Chief Programs Officer, and I also oversee the mobile response team, the Prince George's County mobile response team. Oh, my mindful minute, what summary? I guess I'll say a mindful minute was when I traveled this summer to Greece and Turkey with my 14-year-old granddaughter and 18-year-old goddaughter, and it was chaos. However, not because of them, but things just, it was lemony snickets, a stream of unfortunate events. But the mindful minute is how resilient those two were. They didn't get all excited. They didn't get all, oh my God, none of that. They were very resilient, and they rolled with all of the things that we had to deal with just to get to freaking Istanbul, Turkey. But once we got there, it was okay. But what came to mind for me is that sometimes we sell our young people short in terms of their ability to pivot when necessary. And I just wanted to say that 14-year-old and 18-year-old, they did an amazing job of showing their resilience.
Wonderful. Well, I hope after the hurdles that it did take to get there, that you guys were able to enjoy yourselves. And for everyone who hasn't had their summer activity yet that has re-energized them, I hope that it is coming in the next week or so, and that folks get to enjoy their remaining weeks of summer. Did I miss anyone before we move into our agenda? All right. Well, for today's discussion, as we ease our way back into our meeting cadence, we will start today with a presentation from the Project ECHO team. We'll hear about the implementation of this program in Prince George's County. We'll have some time for open Q&A, have some reflections from the presentation, and have some connection time. We will end our meeting as usual with our community announcements and our upcoming meetings. And to get us started today, we are very excited to welcome two members from the Project ECHO team. We are very excited. I know this team has started giving presentations to the Behavioral Health Division in the Prince George's County Health Department and a few of our partners. So we're very excited to welcome these partners today to give us a presentation. Dr. Harrison and Dr. Lepper, I will let you guys introduce yourselves, and thank you so much for joining us today.
Thank you. Joyce, do you want to start? An introduction and put up the slides? And you're muted.
I was having a not mindful moment as my dog started going insane just as I got on this Zoom. I had to have them swept away. So let me share the slides and let me know if you guys can see these. Can you see them, Mir?
Yes.
So we're not in presentation mode, so let me do that. Make it slideshow from the beginning. Okay. Whoops, that's not what I wanted to do. Okay. All right, we're going back. Oh, I did make a
a title slide, and that's it. So we'll go back to that. In spite of 10 years of working with technology through Project Echo, we almost invariably have some kind of glitch or other when we're trying to show videos or do other stuff. So anyway, I'm Joyce Harrison, and I am a child psychiatrist with special interest and expertise in very young kids. So my preferred age group is birth to 5 or 6. And I am based at Kennedy, although I'm really based in Southern Maryland at my home in Lesby, Maryland, in Calvert County. So my mindful moments are every single day when I do my morning walk on the beach. So I'm going to let Mary introduce herself, and we're looking forward to telling you guys all about the work we do and the work we're going to do with you all.
Thanks, Joyce. Hi, everybody. I'm Mary Leppert. I'm a neurodevelopmental pediatrician at Kennedy Krieger, and I run Project Echo for the Institute. And first of all, I want to just say that we're very grateful for the opportunity to be here today and to chat with you about what we're planning in Prince George's County this year. Joyce and I have been working together for about 10 years now. Both of us are focused on preschool identification of what we call mental health, developmental, emotional, and behavioral disorders, MEDB disorders, which is the way they're being referred to for the Academy of Pediatrics right now. So we've been running echoes in the state and actually around the country for the identification and management of young children with MEDB disorders. And we just want to start with a little bit of background about how big the crisis is right now. Not that you're all unaware, I'm sure you are. I just want to give you some perspective through our lens. So Joyce, if you would advance the slides.
I'm actually going to go back to just talk about our funding. Are you seeing seeing the full slide view or the?
Yes.
Okay.
Yes.
So because I have, okay.
Yeah, we are funded through the State Behavioral Health Administration for 1 year for this ECHO. This is, though, not our first year with the funding. We had funding back in 2021 for 2 years that allowed us to start our first 2 ECHO programs in the venue that we're doing it right now through BHA. Next slide, Joyce. So just a little bit, we will be doing an ECHO, and at all of our ECHO sessions, we give a didactic presentation, and it always starts with 3 objectives and ends with 3 pearls, so that we tell you what we want to really focus on, and we conclude all of our didactics with the pearls or the summaries of the things we really want people to take away with. So we kept that paradigm for this talk today. So our objectives are to define the crisis in MEDB healthcare, really in the country right now, but more particularly in the state of Maryland, to provide to you an overview of Project Echo, and to describe what we're planning in Prince George's County through our ECHO program. Next slide, Joyce. So just for an overview, right now in the United States, the estimate is that there's about 17% of children with a disability. But when you think about MEDB disorders, which aren't all considered disabilities, obviously, that number bumps up to 26% of US children. So 1 in 4 children in the National Survey of Children's Health are thought to have a disorder of mental, emotional, developmental, or behavioral health. That's 19 million children across the country. And my colleague Amy Hartrow wrote a couple years ago that the top 5 conditions. So it's really interesting. If you think about pediatrics 100 years ago, it wasn't quite a specialty 100 years ago, but almost. The reason people brought children to the doctor was because of infectious diseases, measles, mumps, rubella, chickenpox. Those things that thank goodness immunizations have helped us with. And then in the 90s, the reason that children came to the pediatrician, the top reasons were respiratory illnesses like asthma. That's really changed. And now the top 5 chronic conditions for which people seek care from their pediatrician are MEDB disorders, and asthma is now number 6. Next slide, Joyce. So we have this really big demand of need across the country, and we have a really, really small workforce. If you think about what I do, developmental pediatrics, there's 2 board specialties. There's developmental and behavioral pediatrics, and there's neurodevelopmental disabilities, which is what I did. But if you combine those 2, because we overlap a lot, there's one of us for every 19,000 children with one of these disorders, right? So that's why we have such long lines for waiting for, or wait lists for, autism evaluations and learning disability evaluations and so forth. That's my specialty, and Joyce's isn't far behind. So the child and adolescent psychiatry workforce is really compromised as well. There's 70% of counties across the US have no child and adolescent psychiatrist. And I will tell you that within child and adolescent psychiatry, it's really rare that you can find somebody who really focuses their care on very young children. Joyce is kind of unique. She was unique in Baltimore. She was unique in Maryland. And I was really, really lucky to team up with her a decade ago. Prior to the pandemic, half of children with mental health illnesses weren't receiving the treatment they need. So we have a really big demand and a really small supply of medical subspecialists that take care of these children. Next slide, Joyce. So when we look at the need in Maryland, this is from the 2022 report of the National Survey of Children's Health. In Maryland, we're doing a little bit better, right? 23% of children have an MEDB disorder. But of children who have an MEDB disorder, 64% said that they had trouble obtaining mental health care. 44% said that they had trouble getting a subspecialist care. 90% said they're not working in a well-functioning system. And many were frustrated with their ability to get services for their child with MEDB. And many children or parents were reporting that their children had 2 or more adverse conditions, adverse childhood experiences. Okay. So we've got a really big problem, and we have been working with Project ECHO, as I said, for nearly a decade. I'm going to turn it over to Joyce to talk a little bit about what ECHO is and where it came from.
Okay, not muted, am I? Nope. Okay.
Nope.
All right. So I love to talk about ECHO because I think it's just an amazing tool for spreading expertise, knowledge, and improving and increasing the skill level of all professionals dealing with young kids. It started in New Mexico. The gentleman in the picture is Sanjeev Arora. And just really quickly, the story is he started ECHO 20 years ago. He is a hepatologist, a doctor who deals with kidney, liver problems. And he works in Albuquerque, and New Mexico is huge, and people all over the state were waiting a year and a half to see him because of his special expertise in hepatitis C was one of the things that he was treating a lot of. And he realized if he could teach people in remote areas, primary care physicians, how to manage basic hepatitis C, then he could reserve his care for the most complicated cases. And so he started these video conferences to train primary care providers in basic hepatitis C care. And what happened with him was that his waiting list went from a year and a half to 6 months. So people weren't dying who couldn't get to him for care. And since he started this whole movement, is how he describes it, ECHO has expanded beyond just medicine to a variety of topics, including things like immunization, community policing, education. So there are something like 960 hubs across the world. There is a whole Echo India. So it's a huge movement, and it's just so useful for so many things. So we were lucky to stumble on this model, and I'll spare you that story, but I'm just going to show you, or try to show you, a little video of how it works. So let's try this and see how it goes. Oh, let's see. Okay. Nope. I might skip the video. I'm going to try one more thing. I think it's coming. Okay. Let me know if you can hear it. Can you hear it?
No, Joyce.
Okay. I forgot to share on my share video, share audio on the Zoom. If you give me a quick second. Okay. All right. Audio. I am muted, but I want to share. Okay. I am not sure that this is going to work, but sorry I didn't try. I didn't have time to try it beforehand. I'm going to try once more, and then I'm going to give up.
No.
Okay. Okay. I give up. I'm going to go back to my slides. So anyway, it's a really quick video that shows you how it all works. And now I got to get back to my slides. Hold on. Okay. Nope. You're going to see all my stuff here. All right. So, sec. Change my view. Okay. I've lost my, here it is. Okay. Okay, but I couldn't see my speaker view. Okay, I got it now. So anyway, just to give you a sense, the idea is that you have a hub team of specialists that you can see in this little graphic. And the specialists for our particular model are usually myself and Mary, and then additional members, which may be psychologists, a special education lawyer, neurologists, or others who are germane to whatever that topic is. We have ECHO participants, which you will hear about who those may be. We started with all medical professionals, and we've expanded to include both medical professionals and early childhood professionals. And then those participants share their knowledge with their communities. So the idea is that we are building local experts and improving local expertise for the topics, our topic of MEDB. The structure is it's a video conference. It's always video, and we were using Zoom before anybody even knew what it was 10 years ago. And now Zoom is, everybody's got Zoom fatigue, but it is what it is. So we use the Zoom platform. We have an hour. It's usually at a lunchtime. One of the participants will bring us a child to talk about that they're struggling with. They will present the case. Everyone will ask questions. Then we will all generate recommendations for that child. After about 40 minutes, and I will tell you, you're going to hear a little bit about the kinds of children that we hear about, extremely complicated. After the case discussion, then the last 15 minutes or so are devoted to a brief teaching topic, and you'll hear more about this, but that's the structure. So it's really case-based learning where everybody teaches and everybody learns. I think I'm gonna talk to you a little bit about the history of our ECHO. Particularly in the state of Maryland, we have, as Mary mentioned, we have actually national and other international work that we're doing, but this is what our history has been in the state. Our very first one was a HRSA-funded one where we worked with pediatric medical providers in federally designated underserved areas and school-based health centers, which was really kind of an interesting mix. So we were across the entire state of Maryland. We had 4 years of doing that, and when that funding ran out, BHA said, we want you to continue this, but we want you to expand it beyond just the medical professionals to include early childhood stakeholders. And we want you to do a very specific high need region of the state. And so we did the Lower Shore. We did four counties on the Lower Shore where we pulled everybody in, and we'll tell you more about that. It was a challenge for us because we are medically oriented, and so to open these discussions and really learn about all of these other systems of care was really great for us. We had rollover funding, and we started a second ECHO in Southern Maryland in St. Mary's, Charles, and Calvert, where I currently live. So we had these two simultaneous running because the Lower Shore didn't want to stop. So we started this ECHO alumni where anybody who had participated could come once a month and bring cases, and they continue to do that. We've had people who have been with us since 2016 who still continue to join, bring cases, discuss cases. It's really it really is this community of learning that we create and maintain and grow. And so we've been thrilled that BHA said, we want you to do this in Prince George's County going forward. And so you guys will be our newest ECHO starting hopefully in the next couple weeks. So we'll be talking about that. What we wanted to share with you is that this map shows you all of the places where we've had participants. So the Lower Shore and Southern Maryland. These work well when you have about 20 people in a meeting. It just gives everybody a chance to have an opportunity to speak, to get to know each other. Bigger groups, people tend to turn off their videos. So ideally, although you can have as many as 30 or 40 people, but we find, we find that smaller groups often work better. But these are all of the counties that we've had representation from. And then this is what has been really exciting to us is we have pulled together all sorts of people who are involved in early childhood care, education, health, and service coordination. And we found that the particularly like the family service coordinators bring really complicated cases to us and seem to really benefit and absorb all of the things they learn from all of the early childhood professionals. We're going to talk a little more about, what we've learned about the cases. What we plan for our this ECHO going forward is a noon to 1 o'clock, and we will be holding these on the second and fourth Tuesday of the month. From 12 to 12:05, we have introductions and announcements. Then we talk about the case for 35 minutes or so. Then we have the didactic, and then we like to leave a little bit of time at the end for just questions and wrap up because there are always questions and discussion. Okay, the case presentations, I think, just to let you know that the way this model is set up, the cases are de-identified. This is a consultation. So because these are not patients that we're actually physically seeing, we can't know. We have to keep their protected health information protected. So we discussed the cases with all the participants, and we have come up with this rubric to figure out how we take all this information that we gather from the people presenting the cases and the questions that are generated to identify the problem. So this is the challenge is there are usually many, many things going on. And so to distill it down, to figure out the first steps is to figure out what's going on. The second is to prioritize what can be done. And then the third is to plan. So we may generate a laundry list of 10 things, but we'll say, okay, what are the things that we need to do to figure out what's going on? What are the things that need to be done first, maybe to keep this child safe? And then what are the things we can actually do? And let's plan to do those. After we come up with the recommendations, then we will give a summary to the participants so that they can use that, the person who's presented the case. We will often say, this is a really complicated child. There may be 3 things that you can do, but 10 things that need to be done. So let's follow up in a month or 2 and see how you've progressed and what you've been able to do. So we will offer, or sometimes they will say, can I bring this child back for discussion? Or they've tried something that we've recommended. It maybe hasn't worked as well as they want to, so they want to revisit and see what else can be figured out. So I'm going to shift and let Mary talk a little bit about how challenging this work is and how we've addressed that.
Thanks, Joyce. I think everybody knows how challenging this work is, right? There's a lot of disruptive behavior going on. I think more than I've ever seen in my 30-year career. And I think that what's incumbent on us is to try to figure out, especially in young children, really what's going on underneath the behavior, because behavior is a manifestation of something else, right? So young children have a very limited range of behavior to signal any distress. And the signs and symptoms that they manifest may be developmentally inappropriate, or it may be a normative presentation of ADHD or something. So the part of the problems about making diagnoses in these children, especially like with ADHD, you need to make sure that you're seeing those symptoms in more than one setting. We can use validated rating scales, and that'll help us with things like ADHD and anxiety disorder. But the truth is, what we're finding is that it's rarely a single problem. It's usually co-occurring problems that are the rule and not the exception to the rule. Next slide, Joyce. So it's been very interesting because our first echo was really for medical providers, and they were giving us some really tough cases that they were following in their practices. And when BHA opened this up for us, and they said to us, like, start in the lower shore, but make sure you're including childhood stakeholders. So it wasn't just medical, it was pediatricians and nurse practitioners, but as Joyce showed, it was early childhood educators, it was early childhood mental health workers, it was behavioral health specialists. It really was a breadth of people. And everybody had the opportunity to bring cases, and the cases were no different, whether they were presented by the pediatrician or the school teacher or the mental health consultant. None of them were straightforward. And what we learned is that diagnostic overshadowing is a really common problem. Diagnostic overshadowing is this concept that a behavior is so significant that it eclipses anything else that might be contributing to that behavior, right? So when you think about a 4-year-old who's having out of control tantrums or meltdowns that are like impossible to get in front of, you know, what's going on there? Is this really a dysregulated child with ADHD, or is they have anxiety, or is it a communication or developmental intellectual problem? Is this a child who's had a lot of trauma, right, that hasn't been identified? So diagnostic overshadowing is what we're seeing very, very frequently. And when we pick apart these cases with the whole team, right? So when the cases are presented, a person presents it, but then everybody on the call gets to clarify the questions that they have for the person who presented and also give feedback about what they think is going on and what resources they would recommend. So, but when we do sort of dissect the case a little bit, what we're finding is that there's usually a combination of problems going on, and that you know our workforce in early childhood, we're really good at picking up, identifying, screening for single disorders. But when disorders get merged, it gets really fuzzy, right? And so our echo is really to help us tease apart those combinations of disorders. Next slide, Joyce. So what we've learned from our echoes is that, as I said, it doesn't matter who, like, everybody's managing the same behaviors, the pediatric office, the school, the behavioral health consultants, the early childhood mental health, and that disruptive behavior is really, really common problem in early childhood. But that's frequently a manifestation of something else, an MEBD disorder. And what we found in our echo cases since 2016 is that 80% of the cases that have been presented to us have co-occurring disorders. So, you know, rarely is it just a medical, developmental, or behavioral disorder. It's usually developmental and behavioral, or developmental, behavioral, and emotional combined. Next slide, Joyce. We looked at all of our echoes and all of the cases that we've done so far. And when we look at all of them, we know that these are the top 3 diagnoses in each of the MEDB arenas, right? ADHD, speech and language, and social development are the most common developmental problems we see. Aggression and sleep every year sort of vie for number 1. Sleep disorders are super common in these young children. Oppositional defiant disorders. Emotionally, we're seeing anxiety, anger, irritability, and adjustment disorders. And we're seeing a lot of children with ACEs. Over 50% of our Maryland cases that were reported had at least 2 adverse childhood experiences, the most common of which were parental separation, mental illness in the home, and substance abuse in the home. Next slide, Joyce. So we spend about a half hour talking about a case. The case is presented to us. We talk about, we have a system for how to collect the information on the case. And then after the case is done, we close up, we make sure that whoever presented the case, that their questions were answered. And then we move on to this didactic curriculum. This comes from a very large curriculum called the KIND curriculum that we've been building at Kennedy for 10 years. We also, we make sure that everything starts with objectives and ends with pearls. Here's just a list of some of the topics that are included in the didactic presentations, which are only about 15 minutes. They're like really digestible, small bits of information. I think the next slide, Joyce, is this is what we're proposing for the Prince George's County Echo series that will start on September 10th, just so you can see the kind of topics that we're hoping to address. Joyce?
Yeah, so I'm going to take over. What we thought we would do is just give you a little snippet of kind of the way that it works. And I think it's helpful to see the kinds of cases we have. And this is really just a little bit. We get usually more information from this, but just as an example, so a 42-month-old boy is attending preschool for the first time. So this may have come from the teacher. And she says she knows that the parents are recently separated. The mom went back to work full time, and the grandparents are providing care. He has disrupted sleep. That's all we know, but he's healthy. And in the classroom, after being okay for a week or 2, he's become disruptive. He's tantruming. He's aggressive toward other kids, and he's not following directions. And this is sort of classic what we see or hear about. So we may get this little information, and then we open it up and we ask people to ask more questions to try to find more information about. But if you think about this child, what do we think is going on with this child? He may be reacting to trauma, being separated from dad or mom going back to work or being with grandparent. Sleep may be causing dysregulation. We know that poor sleep makes kids irritable, angry, and with a lower frustration tolerance. He may have a developmental delay or language impairment that didn't show itself in the first couple of weeks of school, and he may not be understanding what's going on, or he may have early ADHD, which those guys tend to have a very low frustration tolerance and lose it very easily. So we have come up with a tool, the 8 S's, which we should have showed you before, but we'll probably show you later. We have this tool that we use to try to, and we give this to all of our participants so that they can think about what the things are that might be most helpful to try to sort out what the next steps might be for this child. We learn this from many years of consultation. It's like, what do we absolutely need to know? So the first is always safety. Is this child safe? Does the child make it unsafe for others? And that's usually one of the first things that needs to be addressed. The second is specific behaviors. So we know what these child-specific behaviors are. Those are what we call in medicine target behaviors, like what do we need to go after to make better? Then the setting. So what we mentioned before, to make a diagnosis, you have to have things in more than one location, like ADHD, which is overly diagnosed at times for little kids. You have to have it at home and at school. So we know only about behaviors at school. So we're going to start to ask, what do we know about this child's behaviors at home? Because just school can point you to different kinds of problems than just home. everywhere, maybe something altogether different. Services, what's already been tried, what's worked. We need to know that before we start recommending things, we need to know what's been tried and what has worked or not worked. And then scary is our S for ACEs, adverse childhood experiences or trauma. And the parents being separated, mom returning to work, new caregiver. We don't know. We also don't know, is this child's first school experience? Because that can be a little bit traumatic for kids too. And then sleep. So we started with these 5 S's, which were behavioral, and then we added these developmental S's, which is sleep. We know it's disruptive, but what does that mean? Is it difficulty falling asleep, up during the night, waking up too early? Because those can all mean different things as well. And then social. What is this child's social interaction like? I wrote, these are the questions. We don't know these things. Does he need to be the boss, which is typical of kids with ADHD? Is he interested in other children, which may be a red flag for autism? And any and all of these things could be coming into play. And then speech, children can have really good vocabularies, but still have communication challenges with either their receptive language or their expressive language. Even if it sounds like they have a lot of words, it doesn't necessarily mean they're communicating well or understanding what's being communicated. So this is a framework that we use as we gather information, ask each other questions, and put it all together. And then this is a child which is grammatically horrible, but it's a question that is really, really useful. How old a child do you think this child acts like? Very commonly gives you a clue about whether there may be some developmental delay. School teachers know this well. It's like, this kid is 4, but he acts more like a 2-year-old. They have the whole range of what's average and what's not average. Parents know this well. Parents are really good predictors of where their child is developmentally. So how old a child does this child act like is a really helpful question to point in the direction of maybe some developmental delays in various areas. So there are many possible causes of this child's behavior. We have development, could be developmental, it could be the child doesn't hear, and that's why he's not following directions, or language, as I was talking about. Could just be behavior. These could be typical toddler tantrums. This is an adjustment to this whole new situation. Could be related to the sleep, could be related to multiple caregivers, could be early ADHD. Emotional and dysregulation, again, from the sleep. Trauma, the separation, or maybe there's unknown trauma that we don't. Maybe grandma is really mean and uses physical discipline. Or it could be anxiety. This child is just anxious, and this is the way a lot of kids have tantrums that have anxiety underlying them. So that is sort of just an overview, and what we do in these sessions is really tease this out and figure out ways that we can sort out A, what's going on, B, how we can intervene to keep this child safe and move this child along developmentally. So just to shift a little bit, I think I'm going to finish off that one of the things that we love about this model is that it creates a community of practice. It really builds networks. This is some of the feedback that we've gotten from the participants that we've had across the years, that it's really helpful for people who are rural. Prince George's is not rural, but counties can get isolated and feel isolated. We often operate in silos, so this is a way to connect all of the professionals involved with the care and mental health of young children and education of young children. Another participant, I've gained information that I would not have gained elsewhere, particularly the non-medical professionals often appreciate what they learn about what a pediatrician actually can do or does do, just in terms of, requesting IEPs, what goes on in the school. The pediatricians appreciate what they learn about how the school system operates. But this one, it has made me feel so supported. I think the thing that I like the most about it is that this work is hard, and I think people don't appreciate how hard it is. But when we're all putting our heads together to help a child, we and just having a person bring something they're struggling with and hearing us say, boy, this is a really tough case, it really makes a difference. It really empowers you to continue doing this really difficult work. So this is a really nice rubric about what ECHO does. For patients, it does. Everybody can have access to this expertise. We're really raising the level of knowledge of the providers. That knowledge gets extended to the community, and it changes the whole system. And it's really inexpensive. It gives people access to care. You know, they don't have to wait 6 months to get to Kennedy, or they get Kennedy expertise without the expense, the cost, and the wait. So as Mary said, we always end with pearls. And so these are the things we want you to take away as we finish this talk. One is, you know, diagnostic overshadowing in this age group, this tendency to miss what's going on because you just label everything as behavior, may really delay appropriate interventions. And we didn't talk about this, but the big reason that we do what we do is we know that early intervention is crucial. It changes the whole course of development for children. And so missing these things early really can just create more problems, more expense, more treatment, more medication down the road. And that's what we're trying to avoid. 30 to 40% of children with MEDB disorders have comorbidity. This is the other thing, is these kids are so complicated. And so being able to tease this out and come up with a plan of attack really makes such a difference for the professionals that are caring for these kids. And we really have to figure out what's underneath this behavior so we can deliver these appropriate interventions in a really timely manner to optimize the outcomes. So that's it. We're happy to, that's a lot, we know, but we're happy to answer any questions that you might have as we've thrown all this information at you. So any questions?
There's a question by Mr. Epp.
Hi, Larry.
Oh, yes. Hi. Thank you so much, Dr. Harrison, Dr. Lepner, for doing this. I think it's so needed. I guess the question I had in our Shepherd Pratt school mental health programs, we often see the kind of complexity and dual diagnosis with autism in the higher grades, even K, first, second, and third. Would kids at that age be appropriate for your echo group, or is there a certain, age cap that you have?
So yeah, go ahead, Mary. You can.
We focus on the younger children, really sort of birth to 8, but because the children that you're describing are developmentally much younger, in many cases, we welcome those as cases to discuss as well.
Yeah, that's great, because what we're experiencing is we're seeing people who've never been diagnosed with
Wow.
autism in those grades. So it's a great resource. Thank you so much.
Thank you. Dr. Bierstadt? Bierstadt?
Yes, thank you. I had maybe 2 questions, but when you were talking about some of the developmental issues that might be contributing towards emotional and behavioral issues, I was thinking perhaps there could be maybe something to add to the list is vision. Sometimes if kids are not diagnosed or having trouble with their vision, I'm just wondering if that's something that might contribute if they're not seeing clearly, especially in school.
It's very unusual, and yet we definitely do see it. Vision and hearing impairments, if they're missed, can look awfully like autism in children. I had a young man who's like 4 years old and had a twin, and there's no comparison developmentally between him and his twin. And he just kept picking up the blocks that I had and looking at them like this. And something made me send him to ophthalmology, and he had something like 2,800 or something, some outrageously horrible vision. And at 4, when they put glasses on him, he walked up to the video screen, like the baby Einstein that his brother had been watching for 2 years already, and said, "Apple." And he wouldn't allow his parents to take off the glasses while he was awake. They had to wait till he fell asleep to take off the glasses. So you were so right. It's just, it's pretty, like, it doesn't have the same prevalence as do these other developmental conditions, but you are absolutely right. And hearing impairment, if you have a child who's not responding to their name, the first thing we do is a hearing test before we make a diagnosis of autism or communication disorder or anything else. But we don't do that with vision. You're absolutely right.
Gotcha. And the last question was you're mentioning about it's interesting that this developmental emotional and behavioral issues have become more prevalent, whereas in the past it was more issues with asthma, with children coming to the pediatrician. Uh, why do you think that is? What was the shift, and was what caused this shift where now asthma is fifth in terms of somatic illness, but all of a sudden this becomes prevalent, more prevalent. What
Yeah.
happened?
Well, I mean, the earlier shift was more clear, right? We lost measles, mumps, rubella, and chickenpox with vaccines. So that was an easy shift. But the asthma thing, there are a couple things. I think some are environmental. We've reduced our environmental lead, aerosolized lead levels since we got rid of leady gas. How many years ago? In the 70s, right? 70s, 80s. I think the Environmental Protection Agency has done a lot to reduce the burden of iatrogenic, if I can say it that way, pollutants, the things that we put into the atmosphere as opposed to typical allergens. And those the treatments of allergens now are so easily prevented now with preventative medicine. We're able to avoid asthma exacerbations altogether with just some really simple preventative medicine. So
And
it really has been replaced.
I think coming from the mental health side, is that there's such a shortage of providers of mental health services that people go to their pediatrician. So access to mental health providers is a problem. People trust their pediatrician. They feel safer, talking about some of the mental health conditions, but pediatricians don't feel equipped to deal with these. And so, one of the other benefits of this kind of work, this echo work, is really supporting pediatricians in what they know and what they can do, and empowering them really to do more kind of screening and some intervention, some basic intervention, so that once again, the more complex cases get reserved for the specialists and the mental health therapists. So yeah, I think that it's both of those things. There's a lot, and there is more, the incidence, incidence of autism keeps climbing. There's more mental health problems in the world as well. So as we've learned to manage these somatic problems, the mental health problems, I think, have surfaced and exploded, and COVID really didn't help much in terms of the explosion of mental health problems and developmental challenges in young kids who didn't have opportunities to socialize.
Okay, thank you.
Taylor.
And I'm curious if you're able to talk about the evaluation of Project Echo. I know earlier you mentioned the pre and post participation quizzes. Are those content-based quizzes? Are those going to be more self-reported measures? Dr. Harrison, I know you mentioned the confidence, the empowerment of participants. So what is that evaluation going to look like?
We have several. We do a pre-survey and a post-survey. The pre-survey is twofold: to get an idea of how confident people feel or where their knowledge gaps are. So we really spend time in the pre-survey trying to figure out what are the learning priorities of the people who are going to be in our ECHO. And that's why when I showed you the schedule, it was a draft schedule, because when we get those surveys back, we may modify that schedule substantially to make sure that we're meeting the needs of the registrants. We also make sure that we have at least two sessions that are what we call audience choice. So we kind of move along until November and then say, so what do you guys want to hear about that you haven't heard about? And we'll make special lectures twice a year. We do a similar survey at the end of the whole ECHO, just to see if there's been an improvement in knowledge, in in confidence in caring for these children, and also in collaboration, because that's what we've been finding since BHA asked us to bring all the stakeholders in. The biggest benefit we're seeing is that these local groups, right, the Lower Shore, Southern Maryland, now hopefully Prince George's County, will have this sort of built-in collaboration that didn't exist before. We used to do pre and post quizzes, and they were knowledge-based. We're going to drop those this year because every year we've done it for 8 years, we've shown that it's a statistically significant increase in knowledge. We don't need to keep proving that, and it's just an extra email in your box. So we're going to stop that. We will have one question at the end of each session for those who want to get maintenance or certification. We do provide continuing education, continuing medical education, and maintenance of certification credits through Johns Hopkins CME office.
Okay, thank you. And the link that we're seeing in the chat, that Qualtrics link, that's a link that folks can go to and direct their networks to register.
Please, yeah. We started sending out email blasts a week and a half ago, and we've only had 2 registrants so far. So we're hoping that you'll help us spread the word. We think that this is a valuable use of an hour of time, and we do it at lunchtime to hopefully optimize participation. And, as long as you turn off your microphone, you can eat potato chips. It's fine. We just don't want to hear you eat potato chips.
Absolutely. Well, I have a few names that I've written down of some organizations, some partners that we worked with who aren't on the call today. Spectrum of Hope, I know we had a presentation recently from those folks. I'll get you guys connected. I'm curious, any of our partners on the call, are there any Prince George's based partners who aren't present today who you think Project Echo should get in contact with?
Yeah,
Hi,
oh,
Palma. Hi, Taylor. This is Denise.
Hi, Denise.
Can you hear me?
Yes.
I think we're also coordinating with the local behavioral health authority to have the flyer for Project Echo information to go out to all the provider networks under the LBHA so that we can get more information to register, more participants to register. So that's coming, and we're also working with Amani and Sharice to get the doctors on the LBHA upcoming September meeting for a presentation similar to this one. So I'm hopeful that we'll get more registrants.
Thank you. I see in the chat that both Sylvia and Durana are saying that the links aren't opening for them. I tried both and it opened for me, but it might be because I'm in the network. I wonder, Taylor, if I can send them to you after by email, if you would be able to forward it.
That works. Absolutely. I can include those in the meeting notes.
Fantastic.
We'd really be grateful for any help you could give in disseminating this information. We're really excited to get underway, and it's only September 10th is a few short weeks away.
Right.
And Larry, I saw you came off mute a few minutes ago.
yeah, I guess what I'm wondering, because I know the problem you're touching on is so great. I mean, there is an under amount of resources for kids on the spectrum in Prince George's County. It really is serious. And I was just wondering, like, some of our staff, they feel uncomfortable when a child is on the spectrum treating them for a mental health disorder because many of us got such a poor education in that area. And I mean, if someone takes on a case that's complex as you're um, addressing, I mean, would your group be enough to continue with that case? Or, I mean, I guess I'm wondering what level of support, because I know you have a lot of people in the group, what level of support would it offer, would you say? I just
So I think that would really depend on the case, Larry. You know, I think there are situations where and it would depend on the child and the professional and, you know, their level of comfort, their level of expertise, because occasionally, even though our goal is to not do specialty referral, occasionally we'll help someone and say, you know, this is really probably more complex than you can manage. And here are some resources for you, additional resources for this child, you know, someone who may be in a better position. But, you know, in terms of the level of support, it's enormous because you have a whole community of people who have knowledge and resources and information and connections. So it we find that in general, people become much more comfortable managing these really challenging kids because they have the support of the group, because they have recommendations about, you know, directions they can go in, or even just, you know, people who they can get other support from in other situations. So it's really variable. And the range, I will tell you though, in general, the cases are really complex. And many times there's no other option beside the person who is very remote. You know, we work on the lower shore, there's just very little there. And so we do everything we can to support that person. You know, it may be connecting them up with tele connections or something like that. So
Yeah, and what I think you guys have hit on something really important. I mean, I was thinking you should connect. I don't know if you know Abila Tazano, who just got the consortium grant to do case management for kids on the spectrum in Prince George's County, but that would be a wonderful person to
person to have in the,
yeah,
yeah.
but you're right. I mean, when a child has autism in Prince George's County, it's really hard to get them all the services they need. So I think this really fills a important need.
And
It's true.
to,
It's true everywhere. It's not just Prince George's.
Yeah,
It's
no,
everywhere.
I'm sure it's everywhere. Yes.
and to your point, Larry, and one of the comments is, have we reached out to community pediatric providers, and we're struggling to do that, but it's important because, as you said, our training, when we were trained, right? Autism was 1 in 10,000. Like they told us, you may see one in your career. And so we weren't well trained in this. But pediatricians are more than able to make pediatric providers, nurse practitioners, pediatricians, family practice people, they're all able to make the diagnosis that they need to access services for the children. They just don't have the confidence to do that. And I think that's one of the things we really do work hard on in this ECHO is, you know, just sort of emboldening them to go through the diagnostic criteria, make a diagnosis with it's when it's appropriate, right?
Thank you so much.
And I've included Dr. Tazanu's contact information with Spectrum of Hope in the chat.
I just copied it. Thank you, Taylor.
Absolutely. And to Denise's point regarding our prevention link team, we can also facilitate that connection within the health department. And also the Child Resource Center would be helpful and potentially able to connect those physicians. They have created relationships to the ECHO.
Great.
What's the Child Resource Center?
Eugenia?
What is the Child Resource Center right there? No. Okay.
She's not. Yeah, she's muted.
Okay.
We can figure it out.
Oh, she can't unmute herself. Okay. Thank you, Gina. All right.
Okay.
Any additional questions or any additional thoughts? Well, thank you both very much for coming today and speaking with us. And we have contact information here in the chat. Folks, I'll also be following up with the flyers and contact information in the meeting notes. So everyone will have this, and feel free to share with those who are unable to make it today. I will put in if anyone has to run, I will put in some information for some upcoming community events and our
Taylor,
community announcements.
thank you so much, and thanks to everybody who had suggestions, and thanks for your attention, all of you.
We're really grateful.
We appreciate it.
Absolutely. Thank you.
Okay.
And here is the flyer that we'll be sure
Oh,
to
great.
send out to participants and to share with anyone in your network.
Thank
Great.
you.
Thank you.
Thank you so much. All right, and to close us out, we will open up for any community announcements. First, I know we'll be dedicating some time at our next BHAG meeting regarding the Dyer Care Center, but Margaret, is there anything that you wanted to share with folks? We have the Dyer Care Center, the website is in the chat, that second link if folks want to go and read a little more.
Yeah, we're just really excited. We're almost ready to open, and so I don't want to give the exact date, but I think, our goal is to be open within the next few weeks. And it is for adults. It's the first behavioral health crisis stabilization center. And so it'll be up to 24 or 23 hours and 59 minutes of care. It's really very nice, and they're taking it as an alternative if there are no somatic illnesses or reasons for them to go to the emergency room. This is an alternative to go to the Dyer Care Center. It's really very nice. We had a ribbon cutting probably a couple weeks ago. It's like a very nice lounge chairs rather than beds. And I just wanted to say that we'll try to get the director on to one of these meetings. And then she will probably be reaching out to the community providers. Again, we need that throughput because it is only 23 hours and 59 minutes. Of course, if they need more time, they're not throwing them out, but it would help with getting the throughput and making sure as many people can get the support and help they need. So if she reaches out to you, her name is Faith, and I'm not even going to try to pronounce her last name. But she will be reaching out to you as well as Linwood. They will be, needing partners to refer to so that they can continue that care outside of the Dyer Care Center.
Wonderful. Thank you, Margaret. Congrats to everyone on the call for this very hard-earned effort and for all of the work. And Dr. Bairstow?
So I just want to just let everyone know, it's not often you hear about what's happening in jail. But I do want to mention that we are excited because we have a partnership with, I don't know if you've heard of the Maryland Equitable Justice Collaborative. It's a group of individuals concerned about or have a keen interest in the connection between mental health and criminality and psychopathology. And so with these individuals that have this interest, they're now wanting and going to provide about 20 clinicians to come into the jail to provide pro bono counseling and therapy, because as some of you may or may not know, we have a vendor, but it's only really two people, and our population is 1,100 climbing. So we there's a great need for mental health and counseling and therapy in the Department of Corrections. So if there's anyone on the call who knows of anyone who would like to contribute, or any organization that want to contribute with in terms of working with the Maryland Equitable Justice Collaborative, assisting with pro bono therapy in the Department of Corrections. Down the road, and probably in the near future, there's the state of Maryland has applied for a waiver so that we can actually bill for services, telehealth services, people who are clinicians in the community that want to have telehealth session with incarcerated individuals, and we'll be able to build insurance for it is coming, as well as Maryland has applied for that waiver. So I just want to, I can include my information in the chat if you're interested or know anyone who are interested to assist with the collaborative. So I just want to let you know what's going on. But that's a great thing to have 20 pro bono therapists coming into the jail. Very excited about that.
Absolutely. Congratulations. And thank you for sharing that. And so, Dr. Bairstopp, it's best for folks to get in contact with you or to reach out to the Maryland Equitable Justice Collaborative.
They can contact me. I'll put my information and I can connect them if whoever's interested. So that make probably the easiest way to do it.
Thank you very much. I will be sure to include that in our meeting notes as well. Our next announcement, there is a mental health symposium titled Let's Stop Suicide being hosted on Saturday, September 21st at 10 a.m. It'll be taking place at the Ree Temple Church in Glendale. I have included a link in the chat to register for the event. As you can see, many great partners involved in the event, and we hope to hear more about this symposium's success. And lastly, if everyone has a few minutes after this meeting, Kaiser Permanente's, their community health needs assessment, their partner survey, it is closing today. So if folks have a few minutes, I've included that link in the chat. If folks have a few minutes to give your opinions on some of the leading health priorities in Prince George's County, we would greatly appreciate it. And again, that survey is ending today. So if you have a few minutes to complete that. And did any other partners on the call have any additional community announcements or upcoming events? Wonderful. Well, thank you everyone for your participation today. It was good to see everyone after a long break. We will next convene. Our next meeting is for the BHAG will be on Wednesday, September 18th at our usual time and our usual link. Before that, we are hosting a virtual Prince George's County Healthcare Action Coalition quarterly meeting. This will take place via Teams. I've also included that registration link in the chat. We'll be talking through more about the 2025 Prince George's County Community Health Assessment and prioritizing our data needs and partnering with organizations in the community to see what data needs do we have to capture the health needs and the health disparities in Prince George's County. So we hope you all can join us. And again, that will be virtually held on Tuesday, September 10th, later in the afternoon from 6 to 7:30 p.m. And is there anything else we need to discuss before we close out for today? All right. Well, thank you everyone for your participation. Have a great rest of your week. And as always, let us know if we can be of any assistance.
Thank you.
Thank you.
Thank you. Be well, everyone.
Have a good